My name is Nathalia Costa, and I'm a Senior Research Fellow at the University of Queensland's Clinical Trials Capability Team, the ULTRA team. So I'm a physiotherapist by training, and I was trained in Brazil. I'm very fortunate to be trained there. But in Australia, most of my work is research-based. I think there are many reasons for why low back pain hasn't been actioned by governments. The research we did actually shows that there are over 15 different factors that contribute to the problem. So I would dare to say that there is a lack of cohesiveness, a lack of understanding from policymakers about the problem itself and what can be done to address the problem. So in policy, there is a theory that inaction sometimes can be network-driven, meaning that inaction can be due to a lack of understanding of networks, of driving forces, of relationships in a given system. And the work we did was really trying to shed light on what these factors can be. And some of them are related to vested interests from the specific groups, as well as the community's lack of understanding or misunderstandings that are pervasive in our communities about what low back pain is and how to treat low back pain. There are also some challenges regarding who people should see when they are experiencing low back pain symptoms. So we, of course, have a lot of different practitioners who can provide care for low back pain, but for consumers to understand what a physiotherapist does is different from what another allied healthcare professional like a chiropractor does can be quite challenging for a layperson. I think the pooling of knowledge and different perspectives can contribute in several different ways. Number one, I think it really helps us to understand more about the context and really shed light on some of those challenges. Our research identified over 15 of them, and in today's workshop we identified even more challenges associated with this policy in action. So it really helped us to understand the problem in a more comprehensive way, and if we use the pooling of knowledge to push for action, if we really try to create a cohesive environment to push that agenda forward and really help policymakers to understand the problem and how it can be tackled, I think then we can do a lot for changing the way that low back pain care is managed or addressed by governments. So our research has shown there are many different challenges that hinder low back pain care in Australia, including these vested interests that I mentioned earlier, the fundings, the mismatch between what gets funded and what evidence suggests that works for low back pain, including, for instance, lack of subsidies or very low subsidies for allied healthcare professionals. In the chronic disease pain management, we only have 5 sessions per year for people with chronic conditions such as back pain. So this is certainly something that could be improved. There are also challenges relating to identifying health inequities in terms of who really is more likely to suffer some of the consequences of not having access to care. So many different groups that are marginalized, including people who live in rural areas and don't have access to certain treatment approaches. So there are challenges surrounding the societal stigma, the different communities of practice that we have, different clinicians prioritizing different interventions, market forces. So there is a whole lot of factors that hinder low back pain care in Australia. However, our research has also shown that there are many ways of improving it. And across all the interviews that we conducted, everybody talked about the importance of collaboration, because healthcare professionals, researchers, funders, policymakers, we all work in silos, and that doesn't do any good for us as a community in terms of addressing the problem. So really collaborating, bringing people together, doing things like a summit could be a way of at least starting a conversation that creates a common ground, a common understanding about different ways of tackling the problem. And then also building on that collaboration, trying to push for certain changes. So we have enough evidence that would, for instance, support the use of the multidisciplinary care in the community. It doesn't need to be tied to a tertiary service. So just drawing from what we know that works, drawing from what we know doesn't match evidence, and trying to create alternative ways of tackling some of these factors. Funding impacts low back pain in many different ways, and some of them are not as obvious. Of course, there are market forces, there are different industries that benefit from the over-medicalization of low back pain, for instance. So if we don't have policies or systems of surveillance to really monitor what is being given to patients and how much each of these approaches is actually costing, especially if these approaches are not based on sound evidence, that creates a mechanism that enables the pervasiveness of inadequate care for back pain. I guess the other way, a fee-for-service model can really prompt several clinicians, and I'm talking about any clinician, any stakeholder that provides care for low back pain. It really tends to push clinicians to provide care and do things in repetitive ways rather than really devoting their attention on making people actually improve. So the fee-for-service model doesn't help because we, or clinicians, get the financial incentives to repeat care and do things as opposed to being rewarded financially for the improvement of their patients. So in an ideal world, whether patients improve or not would be a way of creating mechanisms for financial incentive. That would be, ideal, I guess.